My name is Jeremy Hsu. So I'm a general surgeon by training, but I have subspecialty training in trauma and surgical critical care, as well as breast oncoplastic surgery. For a long time, it's been thought that rib fractures they'll heal. And they do heal, but rib fractures cause quite a lot of morbidity. So there's a whole lot of people that don't really get back to their normal activities or back to work after they've sustained significant chest wall trauma, i.e. rib fractures. So there's been lots of different systems in the past about surgical stabilization of those rib fractures. And there've been some results that have come out to suggest that there's benefit in doing that in terms of getting people off the ventilator in ICU and having a shorter length of stay. I think one of the difficulties is that those historical papers also paralleled the improvements in critical care. It was really kind of interesting because prior to that I was always thinking that we just manage these rib fracture patients non-operatively. We give them good pain relief, we help them with their oxygenation, and it's fine. And then I got exposed to these systems now that seem to be specifically designed to facilitate fixation of the ribs. When you're talking about the surgical management of patients with rib fractures, there's lots of terms that have been put around, rib plating, RF, we also say SSRF. When we talk about the actual fixation, it is open reduction internal fixation of the rib fractures, the term that we like to use is the surgical stabilization of rib fractures, so SSRF. We're still kind of working that out as into which patients would definitely benefit from it. The data would suggest that any patient who's in the ICU on a ventilator who has a flailed chest would benefit from having SSRF because then they get off the ventilator quickly, they reduce their chance of needing a tracheostomy. Really, we've taken it kind of to extend those indications and, as I said previously, really to try and prevent those complications from occurring. One of the high-risk features is 3 or more rib fractures that are bicortically displaced. In those patients, we will consider SSRF. And I think that the patients that benefit are the ones that have significant pain. I think if they're having, obviously, the pain limiting their inspiratory effort, then we'll consider SSRF. I think that there's probably minimal benefit to operating on somebody whose rib fractures either doesn't have many of them or that the ribs aren't displaced, so they're broken, but they're in apposition, and so they're not clicking on each other, when they breathe. I think those patients we wouldn't really consider for fixation. So there's pitfalls in surgical stabilization of rib fractures. Some of the pitfalls include selecting the right patient, selecting the appropriate timing, because a lot of the patients have multiple injuries. And so even though we know that fixing the ribs early is better than late, sometimes they have other injuries that have to take priority to that stabilization. So it's really important with that. Then, there's all these things about the actual technical aspect and planning. So I think how you get to the rib fractures is really important. Having all of your appropriate identification, be it that you use CT with 3D recons, whether you add ultrasound marking of the rib fractures, all of that can help guide your incision, because if you make the wrong incision, you either then have to make a really big incision to get to them all, or you have to struggle. I think that in terms of the actual technical aspects of fixing the ribs, it's obviously, as I mentioned, exposure, but when you get there, you want to make sure that you adequately reduce that rib fracture, particularly if they're displaced and telescoped. You want to reduce it back to anatomical, so you've got cortical apposition, just general orthopedic principles. And I think that then having the plate, doesn't matter which system you use, but having the plate appropriately placed over that rib fracture, it's important to understand the orthopedic principles of open reduction, internal fixation, but you've got to also understand then about accessing those actual rib fractures and how you get to that. Well, before I came back and started using the RibLoc system, there was nothing, because no one had ever done any rib fixation. During my fellowship in Seattle, that's when I got exposed to this surgical stabilization of rib fractures, and the system that was used was the RibLoc. And it just happened to be, I just made an inquiry, as in, do we have RibLoc in Australia? They had everything. I was super keen. We got our first case done and sort of have continued through with that, and then obviously onto the U+, which we're really excited about. The use of the RibLoc system, as you mentioned, really started off because that's what I was exposed to, that's what I was familiar with. But then as I went along, and in particular when I'm training the fellows, having, with the U+, having that conforming plate, so it sits over the top of the rib, but it conforms to the rib, which means that then the reduction of the fracture, I think, is more consistently held in place because you have this plate that's conforming to the rib. And certainly I think that there are potentially, there's less room for technical errors by having a conforming plate. It does provide a stable construct, variable lengths, that it does allow a degree of flexibility in terms of picking the right length for that fracture pattern, but still being secure, particularly over the longer fractures or the multiple comminuted segments that I can get onto and have a secure point of fixation where I don't have to worry about the plate sliding on the rib. So that, those are the sorts of things that I find useful about the RibLoc system. From my perspective, I think it's really important to partner with industry to help develop systems and improve the systems so that patients get better care. And the other aspect to that is that obviously then the education for surgeons is critically important, and I don't think that you can do that without partnering with industry, with assistance, and I think the partnership there, then that can really then enable surgeons to kind of get exposed, get their hands on in a safe environment to the system, get trained properly, because then you've got surgeon facilitators that are familiar with the system. That's the sort of thing that I think is important about that kind of partnership.